In this video, we will build on the knowledge previously reviewed on metabolic and physiological adaptations in pregnancy and how they relate to nutrient requirements for pregnant women. We will focus on energy and micronutrient requirements. And I'm very glad that we have an outstanding expert with us today, Professor Hildegard Pschyrempel, who has worked for the German Federal Institute of Risk Assessment and also for the European Food Safety Authority. Long-term health of people is influenced by their mother's nutrition before and during pregnancy. The supply of energy and nutrients has a direct impact on fetal growth and body composition. So what are the recommendations today for energy supply during pregnancy?
Many people still believe that a pregnant mother has to eat for two, herself and for the unborn baby. However, this is not true. In reality, the energy requirement during pregnancy increases only slightly. In fact, about 10% over the whole pregnancy. That means that an additional 250 kilocalories per day would be sufficient. So no increase of energy intake during the first trimester, but some increase in energy intake for a woman who starts pregnancy with a normal body mass index.
And what about women who enter pregnancy not with a normal body weight, but either with a low body weight or with overweight and obesity?
Physicians taking care of pregnant women should, of course, determine the permitted weight gain during pregnancy on an individual basis. That means that a woman starting pregnancy with a very low body weight may, of course, increase more in weight than a woman starting pregnancy with a very high body weight.
Is there advice on the normal gestational weight gain?
Yeah, we think that a weight gain between 10 and 16 kilograms over the whole pregnancy is normal. We also must take into account that this weight gain is uneven distributed throughout pregnancy. That means in the first trimester, practically no weight gain, and the real weight gain occurs in the second and third trimester.
Now, there are these recommendations by the World Health Organization and others on the increased energy needs in pregnancy. How are they actually derived? What are they based on?
They are based on calculations mostly, calculations with the help of data. So there are several possibilities how you can calculate the energy cost of pregnancy. WHO, FAO have done it in two ways. They have on the one hand determined it by the increase of the basal metabolic rate plus the energy cost of deposition of protein and fat and so on. And on the other hand, they have done it by measured data on total energy expenditure plus, of course, the cost of deposition of protein and fat. The nice thing about these two kinds of calculation is that they come out with practically the same result, which is very reassuring about the correctness of this calculation, which means that a whole pregnancy costs about 77,000 kilocalories. The factual increase in energy intake of pregnant women can be much less, for instance, only 20,000 kilocalories throughout the whole pregnancy, and the outcome is still a normal child. This may be that these calculations of FAO, WHO do not take into account the decrease in physical activity in the latter part of the pregnancy.
If we want to achieve these approximately 200 kilocalories or 10% more energy intake at the end of pregnancy, they have to come from the energy providing substrates, which are carbohydrates, lipids, and protein to some extent, although protein is more a building block. Does it matter how they are distributed? What proportion of macronutrients should be provided?
There should be some modification, perhaps, of the quality of the food you consume, because it's not only the extra energy, but during pregnancy you need some extra protein, which is deposited not only in the fetus but also in the mother. So we have an increase of protein requirement during pregnancy. And this means that you have slightly to modify the contribution of foods to your energy intake. That means you should preferentially increase your protein intake, your carbohydrate intake, but certainly not your fat intake. So your fat intake should be the same, between 15 to 30% of your total energy intake, while the percentage of protein contributing to energy may increase a little bit. Normally we recommend something between 10 and 15% during pregnancy. It should be more close to 15% than to 10%. And the rest, of course, should be carbohydrates, which is also non-pregnant, for non-pregnant women, 55 energy percent.
So we discussed dietary protein intake. What about the supply of dietary fats?
Attention should be paid to the quality of the fat. Particularly, one should take care of a sufficient amount of intake of the essential fatty acids, linoleic and alpha-linolenic acid, and very important during pregnancy, care should be taken that a pregnant woman takes about 300 milligrams of the very long-chain polyunsaturated fatty acid, docosahexaenoic acid. This acid, it's only present in animal-derived food, but particularly in oily fish. That means that a pregnant woman should eat per week, or is recommended to eat per week, 2 portions of fish, one of which should be oily fish. What pregnant women should avoid is saturated fatty acids, and particularly trans fatty acids. Trans fatty acids we find mostly in processed foods, or fast food, as we call it. These trans fatty acids.
French fries, the fried foods as well, right?
Yeah, fried foods as well. These trans fatty acids have some adverse effects on the cardiovascular system, including endothelial functions, and they have also adverse effects on the growth of the fetus, apparently, and they apparently compete with the transport of the essential fatty acids from the mother to the fetus. So the fetus is less provided with essential fatty acids when the mother consumes a lot of trans fatty acids.
Now, the other big energy source, of course, is carbohydrate. Is there anything to consider when choosing carbohydrate-rich foods?
There's certainly no reason to restrict the consumption of carbohydrates. On the contrary, if you increase only your protein intake in a very small amount, you try to limit your fat intake, you may have to increase your carbohydrate intake, but you should take care that you consume practically only carbohydrates with a very low glycemic index. The glycemic index is an index which shows you, compared to glucose, which has a very high glycemic index from 100, which shows you how a carbohydrate differs from glucose. What you see then in your blood when you consume, for instance, glucose with a high glycemic index, a very rapid, very high increase of blood glucose, and an accompanying very rapid, very high increase of blood insulin. And you see at the end of some 2 to 3 hours a negative rebound even. That means you have very big differences in your blood glucose levels, which appear to be of adverse effects. You have very high increases, and in the end you have even very low blood glucose levels. Both are not very good for your fetus.
And in pregnancy, obviously, that's more important because insulin action is reduced. There's insulin resistance in pregnancy physiologically, and therefore if you eat a lot of sugar, the blood glucose response is even higher than in non-pregnant women.
Yeah, and this is why we recommend to consume preferably carbohydrates with a low glycemic index. You will have a slower and a lower rise in your blood glucose levels, and you will also have a lower and a slower rise in your insulin levels. And this has apparently the effect that this almost physiological insulin resistance, which accompanies pregnancy, is lessened. And it means also that in women with gestational diabetes mellitus, you need less insulin for the treatment.
So thank you very much. That was a wonderful discussion. It was a lot of valuable information. In conclusion, during pregnancy, one doesn't need to eat for two, one doesn't need to double the food intake, but rather one should think for two, in other words, look more at the quality of food selection. We'll now focus on the supply of vitally important micronutrients during pregnancy. Compared to the needs of energy, the needs for many vitamins and minerals increase considerably more. Have a look at this graph to understand the need to consume nutrient-dense foods such as fruits and vegetables, low-fat dairy products, and whole grains. The average energy requirements in pregnancy increased by only 10%. In contrast, the average dietary needs for some critical nutrients, such as folic acid and iodine, increased by as much as approximately 50%. Still, others only increased slightly or not at all. It is therefore especially important to enhance the nutrient density of your meals, the quality of the diet, rather than increasing the portion size or the energy content. Drugstores, pharmacies and supermarkets offer a wide variety of multiple micronutrient supplements for pregnant women, and they also advertise the use of micronutrient supplements during gestation. The composition of these supplements varies greatly depending on the country and the brand. However, basically all of the supplements tend to contain the key micronutrients folate, calcium, iodine, vitamin D, and vitamin B12. It is generally agreed that iron is also vitally important during pregnancy, but generally it should only be prescribed by doctors when a deficiency has been confirmed by blood analyses. An exception are populations where iron deficiency is very common and where national guidelines recommend iron supplementation to all pregnant women. It is universally agreed to that every pregnant woman should supplement folic acid. This is important not only because of the physiological role of folic acid, but also because the increased needs are unlikely to be met with the diet alone. Folic acid supplementation on top of a selection of folate-rich foods, such as green leafy vegetables, legumes, and folate-enriched flour or salt, is necessary even before conception. Folate supports cell growth, it supports growth processes, and most importantly, it is very effective in reducing the risk of neural tube defects. Consuming a diet poor in folate or having a family history of neural tube defects poses an additional risk and emphasizes supplementation even more. Folic acid supplementation should start already before conception with at least 400 microgram folic acid per day, and it should be continued at least until the end of the last trimester with at least 400 to 600 microgram folic acid per day. In many countries, pregnant women are advised to take iodine supplements on top of consuming iodine-fortified food products such as iodized salt. This is because even a mild deficiency of iodine during pregnancy can cause adverse effects in the child, in particular impaired brain and cognitive development. The need for iodine supplementation should be assessed on a population basis. Iodine is not only important for the mental development of the offspring, but it also plays an important role in fertilization, and it is vital for meeting the increased demand for thyroid hormones during pregnancy. In this context, it has been found that the thyroid hormone T4, which plays a crucial role in neuronal differentiation and development, is reduced in its levels in the fetus even when there's only a mild iodine deficiency and the mother still can be classified as being euthyroid. Before pregnancy, a daily intake of 150 micrograms iodine per day is advised. However, women during pregnancy should increase the intake to 220 micrograms per day, and this can be achieved through a combination of supplements, the use of iodized salt, consumption of commercially fortified food products, and seafood, which is naturally rich in iodine. Iron is needed to support fetal and placental growth, as well as the increasing blood volume of the mother, particularly during the second and third trimester. Fortunately, there are regulatory mechanisms of the body to increase intestinal iron absorption, and of course the blood loss due to menstruation is no longer a concern in pregnancy. Prophylactic supplementation for all pregnant women is not recommended except for some populations with a very high prevalence of iron deficiency. All women should aim at consuming food sources that contain adequate amounts of highly bioavailable forms of iron. These include in particular meat products, and fish. Some plant foods, for example dark vegetables, are also rich in iron, but the iron from plant foods is much less well absorbed. Bioavailability from these foods can be enhanced by simultaneous consumption of vitamin C-rich foods, for example orange juice. The differences in bioavailability of iron make vegetarian and vegan mothers at risk for developing iron deficiency and iron deficiency anemia during pregnancy. Iron deficiency during pregnancy has been associated with an increased risk for low birth weight and for preterm delivery. The need for iron supplementation should be assessed individually for every woman based on medical consultation that includes medical history and blood tests, for example, a measurement of serum ferritin levels. In order to meet physiological needs, the recommendations, for example, the United States, Australia, Germany, and also from the Global Federation, FIGO, almost double the recommended daily allowances from 15 to 18 milligrams for non-pregnant women to as much as 27 milligrams in pregnant women. Other recommendations, in contrast, for example, by the European Food Safety Authority in the UK, do not change the recommended iron intake for pregnant women as compared to non-pregnant states. The recommended intake for calcium for pregnant women does not differ from the recommendations for the general population. However, in pregnancy it's even more important to actually achieve the recommended intakes. Skeletal integrity with adequate calcium storages should preferably be achieved already before pregnancy, as calcium is mobilized from the maternal skeleton during pregnancy to support fetal bone development and growth. An adequate maternal status can be achieved by an intake of 1,000 to 1,300 milligrams of calcium per day, both before and during pregnancy. Dairy products are the main source of well bioavailable calcium. If, however, the access of dairy products is limited for various reasons, such as a vegan diet, cultural reasons, or cosmic allergy, alternative sources are green leafy vegetables, fortified soy products or cereals, sardines and anchovies when they are consumed with bones. Also, some traditional foods, such as nixtamalized or calcium hydroxide soaked maize flour, can be an important source for dietary calcium. Therefore, even when the consumption of dairy products is low, adequate intakes of dietary calcium can be achieved when making the right food choices. A particular risk group is adolescent girls, as they additionally have to support their own skeletal growth and therefore might require additional calcium during pregnancy. In terms of bone mass development, calcium can only exert its action in conjunction with vitamin D. Vitamin D contributes markedly to the formation of stable bones by enhancing calcium absorption in the gut and by supporting calcium deposition in bone. The vitamin D requirements during pregnancy increase because the fetus is totally dependent on the maternal pool of vitamin D. The main source is endogenous production in the skin in response to sunlight exposure. Much smaller proportions of total vitamin D supply are provided by the diet, mainly from egg yolk, oily fish, and liver. A recent review, including 17 studies around the world in pregnant and lactating women, has shown that vitamin D deficiency is highly prevalent even in areas with high sun exposure around the year. Vitamin D status has been found to be even more reduced in obese women compared to normal weight women. Therefore, they are considered another high-risk group. International guidelines on vitamin D supplementation and the recommended dietary allowances for vitamin D are somewhat controversial and different between different groups. For example, the global FIGO recommendations advise a vitamin D supplementation of at least 400 international units before pregnancy and of at least 600 international units during pregnancy. In contrast, the World Health Organization does not recommend supplementation due to the limited evidence on risks and benefits. Vitamin B12 sufficiency is of concern in women who follow a vegetarian and particularly those who follow a vegan diet. Vitamin B12 is essential for the formation of red blood cells and is also required for normal neurological function. This vitamin is contained in appreciable amounts only in animal products. Having followed a vegan diet for several years can lead to severe and long-lasting damage to the child's nervous system unless vitamin B12 is supplemented. Also, in malnourished communities, vitamin B12 deficiency is a matter of concern. Its biological importance therefore justifies an increased RDA of 2.6 microgram per day during pregnancy. The relative increase of the requirement of some micronutrients is much higher than the additional energy requirements in pregnancy. This supports the recommendation to consume nutrient-dense foods rather than simply increasing energy intake. Physicians should be aware of possible nutrient deficiencies in certain risk groups, particularly in terms of micronutrients. And they should consider recommending or prescribing micronutrient supplements, particularly in those risk groups.